to talk about this first trauma-informed principle of safety as it relates to group psychotherapy. And to begin that conversation, I think we have to start at the beginning. Before we start a psychotherapy group, first we have to consider our screening and assessment process, our pre-group selection process, as it relates to that group. Irving Yalom has a quote in his book. He's one of the most famous group psychotherapists. He says that good group therapy begins with good client selection. Clients improperly assigned to a therapy group are unlikely to benefit from their therapy experience. So, this really rings true in my experience as a group therapist and as an organizational leader and director of a group therapy program and inpatient, that one of the primary factors that leads to successful therapy groups is thorough pre-group screening and assessment. And one of the primary things that leads to unsuccessful groups or very chaotic groups or conflict that's difficult to resolve in groups or retraumatization in groups or just simple dissatisfaction in groups is when we really do a sloppy job of pre-group screening and assessment. So this pre-group screening and assessment really promotes a sense of safety for the individual that we're screening, but also for the rest of the group. Safety is threatened when an agency or group worker accepts a client to a group who really needs a different level of care or a different type of group treatment. Groups function best when there's some sort of overlap between the individual goals and experience and the collective goal and experience. And one of the things that I think is especially important in assessing appropriateness for a group that doesn't get talked about enough is that we're bringing together a collection of individuals, and we need to assess that their window of tolerance is somewhat similar. That if we have a bunch of people in a group who have a really wide window of tolerance and they have lots of coping skills and they're able to tolerate difficult emotions, and they've already done some of the early stages of trauma recovery and they're ready to go into trauma processing. But we also have others in the group who have a much thinner window of tolerance, and they might not have coping skills on board yet. They might not have internal ego strength and internal resources that they've cultivated, and they're in an earlier phase in their trauma recovery. It can really lead to incongruence in where the group is at in their recovery process, and it can make it difficult for us as the facilitator to meet all the needs of each individual in the group. And that some people are ready to go deeper into trauma processing, while others are really not ready to do that or be in the room while other people are doing that. And other people with a thinner window of tolerance might need more of the foundational trauma recovery skills, psychoeducation, coping strategies, strength-based work, whereas others in the group may have already spent weeks and months and years doing that, and they might get bored by redoing that again for too long. So we really want to assess each person's window of tolerance and try to put together a group where there's lots of overlap and similarities in the size and threshold of one's window of tolerance. Also helps to consider where each person's at in their recovery process from trauma. If we have a bunch of people that are brand new to trauma recovery, and we put them in a group with a bunch of people that are in phase 2, ready to do trauma processing, or even phase 3, where they've done some trauma processing and they're really ready to do that integrative work and focus on growing from trauma, meaning making, it really limits our ability to meet everybody's needs. It helps as much as possible to put together groups where people are all somewhat in a similar level, some similar phase of trauma recovery. And so what I'm referring here to is the 3 different phases of most clinical maps for trauma work. And there's a whole nother video focused on this channel that I encourage you to check out. But just a simple overview, phase 1 is about safety, strengths, coping skills, psychoeducation. Phase 2 in trauma therapy is about trauma processing, about working with defenses, protector parts, about dealing with the rage and the grief and the despair and the harm, the memories. And phase three is about transformation, about post traumatic growth, about integration and meaning making. So these are the three phases of the clinical map for safely working with trauma. Some general criteria that I find helpful in screening for trauma therapy groups in general, and especially psychodrama groups, are the following: willingness to engage in trauma work, psychiatric stability, suicidality, psychotic symptoms, medications, emotional containment skills, and the ability to tolerate discomfort, behavioral containment skills, so that we can ensure that this individual isn't going to disrupt the sense of safety for the rest of the group and other participants in the group, frequency or severity of drug use and alcohol use or other process addictions or behavioral addictions, the level of social support that an individual has in their life in terms of family or friends, an individual therapist, community support, uh, peer support groups, and other support services, the expected length of time that the individual is going to be in treatment. I think this is especially important for inpatient groups where somebody might only be an inpatient for 2 or 3 weeks. Does it make sense for us to put them into a trauma therapy group in inpatient if we know up front that their insurance is going to cut them off a week from now? Probably not. But if we know that they're going to be in treatment for 3 or 4 weeks, or based on our best guess, considering the medical criteria they're presenting with and the insurance policy that they have, we could expect that they're probably going to be in treatment for 2, 3, 4 weeks. That would make a little more sense to put them into a trauma group where we can open some things up, but also have time to integrate and close up what we've opened before they have to discharge. We also want to know about their ability to continue trauma therapy at the next level of care. So if we know that somebody's about to lose their insurance coverage, maybe it doesn't make sense for them to start trauma therapy for 2 weeks while they're an inpatient, knowing that they're not going to be able to continue treatment when they leave. It also helps to have some congruence between the individual's presenting symptoms, their issues that are important to them, their goals for treatment, and the larger group as a whole goals and issues that are going to be addressed. So these are really meant to be guidelines, just things that I found helpful in my work in assessing for trauma therapy groups specifically and psychodrama groups. And these are going to need to be adapted for each agency and for different levels of care and different treatment settings. Again, Yalom suggests that the majority of clinicians do not select for groups therapy. Instead, they deselect who's going to be appropriate for group therapy. So it's really important that we not only have inclusionary criteria and we have a sense of who we're going to include in this group, but also that we have some exclusionary criteria. Who are we going to exclude from this group for their own safety and for the safety of the rest of the group? Who's not a good fit for this group? Now, many of us, as helping professionals, we got into this field because we want to help as many people as we can. And we might have a tendency or an inclination to want to include everyone, regardless of where they're at in all of our groups. And yeah, this might be a good intention, but I found that it really doesn't work well unless you're going to do more of a phase one type of group that's focused on coping skills and psychoeducation and group cohesion and relationships, safety, and you're not going to get into heavy trauma processing. If you're going to get into heavier work and trauma processing and rage and despair and really get into the depths of pain with clients and their trauma, then we need to have more exclusionary criteria. So I really encourage us to consider this in our pre-group selection process.